Hello, everyone. Welcome. Dr. Noble, if you are asking questions about what do you do? What do you do if you have a child on an ADHD medication and you're worried that they're on too much? Like what are the steps that you can take? This is your live stream, everyone. Welcome to the live stream. As always, if you have questions, you can put them in and we will do our best to answer them as we go through this. I think this is going to be great. Thanks for joining us.
That dog grew this very good mustache.
All right, everyone, let's get started. How do you know what to do when your kid's on too much ADHD medicine? So if you joined me on our previous stream, we talked a little bit about how do you know your kid's on too much ADHD medicines to begin with. Now, again, the point of these live streams is not fear, shame, and guilt, right? That's not what we're trying to do here. What we're trying to do here is give you information about how to use the least amount of medicine possible to ensure your child benefits the most from these interventions. And, you know, when we think about the dashboards of life, we think about school and grades are going well for the child, but if they're on too much medicine, right, then they have issues. They can have issues with physical problems, emotional and social problems. And again, if you're not knowing exactly what I'm talking about there, I'll link that video up above or put it in the link below because I talked about that yesterday. But today, we're talking about how do you deal with medication strategies that are targeting kids that are on too much medication. So we're going to start with weight. Let's start with weight. All right. So here is our down, weight, stop, change paradigm. All right. This is how we're going to go through our time together because it's going to help you understand which of these strategies need to be implemented based on the problem that your child is experiencing. So let's go through this. So this is what we're going to do. With any of these strategies, we're either going to go down, we're going to wait, we're going to stop, or we're going to change. So let's take a look at what we're going to do with this. All right. So when it comes to weight is the first thing we're going to talk about, right? When you got a child who's not growing well, appetite suppression, it's a big issue. There's concerns. Essentially, what you're going to do there is you're going to think about going down. But really, when you go down on a medication, this really depends on the effects, right? So the question you need to ask yourself is, if a child's not growing well on an ADHD medication, right? Their appetite suppressed, they're falling on the growth charts, as we talked about yesterday, you don't feel good about it. You can think about going down. You can think about decreasing the medication, but the question is, how effective is this medication to begin with, right? Like if you decrease the dose, yes, it's possible that the appetite may improve to some extent, but it doesn't solve the bigger problem of why are we taking this medication to begin with, right? If you go down on a medication, right? Yes, your child's appetite may improve, but if the medication is not effective at its current dose, going down won't help you. Okay. So sometimes I go down on the medicine. I go down on the dose. Absolutely I do, but it depends on how effective the medicine was to begin with. Okay. So put a pin in it. It depends. It depends on how effective it is. So I almost never, when we're dealing with appetite suppression, when we're dealing with severe appetite suppression, you're dropping percentile lines, you're living at the 3rd to 5th percentile, you've crossed 2 major percentiles, your body mass index is in the 3rd to 5th percentile as well. We don't wait. We don't wait around and hope for the best. We don't just hope things go better. We make changes. We don't just wait and do nothing. But sometimes I'll stop. Sometimes people say, well, maybe you should just stop the medicine, right? I mean, if they're dropping percentiles and their weight's decreased, let's just stop the medicine. I will say, no. Now that depends. That depends. And this is going to come up a lot during our time tonight. Okay. It's going to come up a lot. And again, if you're new to the stream, put your questions in the chat and we're going to take a look at them together. We're going to see what your questions are. We're going to go through it. But what I will do sometimes when it comes to the dose, I'll say, listen, well, it depends on what dose we're talking about, because your knee-jerk reaction is to say, your knee-jerk reaction is to say, if my child is struggling to grow or they're losing weight, that is by far and away the number one complaint that I hear over 20 years of doing this. It's my child's not growing well. And what happens is people say, well, I'm just going to stop this medicine. I say, well, listen, you can stop the medicine, but it depends on what dose you're on. There's several ways to get out of a building. Okay. And it really depends on how high up in the building you are when it's time to get out. right? You want to take the escalator, take the elevator, take the stairs. But if you're on the 12th floor, you're probably not going to get out of that building through a window, right? It's not a good idea. If your child is on a max dose of an ADHD medication, and again, that there's a lot of caveats to that, but if they're on a very high dose, you're not just going to abruptly stop that medication. You're going to want to do it in chunks or pieces by working with your primary provider. Now, there are times when people do abruptly discontinue the medications, and I have done that personally by taking these medications, and it's not a good ride. Doesn't Google well. It doesn't feel good. It can be really hard depending on who you are and what dose you're on. So I would encourage you, to think about coming off that dose slowly if you're on the top end or high end dose, right? And then lastly, let's look at this. So, and again, rounding out our ideas on how we're going to deal with weight. Okay. You can, if you have a child who's struggling to grow, there are some things that we can do together that might be effective in regards to change. Okay. We can go down. I don't advise waiting. You can stop the medication completely, but again, that depends on the dose. But lastly, and most importantly, there are things we can do to change. There are things that we can manipulate to change the issue in regards to weight. The first thing we can do is diet. Now, there are a million things you can do to add calories to a child's diet. And I know, listen to me, I know what you're saying right now. You're saying, well, you don't understand. My kid eats 4 things. Okay. I mean, if it wasn't for chicken nuggets and like French fries, we'd have a real crisis on our hands in my clinic, in the clinic that I'm a part of, because, kids are picky and I get it. But there are things you can do from a dietary standpoint to add calories, to pump calories into the diet. And typically, you know what it is? You want to know how you do it? It's typically things that kids drink. All right. By that, I mean smoothie consistency items. If you go on YouTube and you look around, you look for smoothie, calorie dense smoothie formulas or ingredients, you can find it. You can boost your kids' calories really quickly. It can be really impressive and really helpful, but you can do it. You can also switch, to a less aggressive medication strategy. Now you're thinking, well, aren't all ADHD medicines created equal? No, they're not. Some are much more aggressive than others. And as parents, you don't understand. I'm going to show you a slide in a minute about how do you know if your child's on an aggressive one or a less aggressive one, and if that's even an option. But you can potentially, you don't have to quit ADHD medicines, right? But sometimes you need to think about switching to a less aggressive strategy. Sometimes you can switch to a non-stimulant. Now, let's talk about it. A non-stimulant is medication strategies that don't involve traditional ADHD medications. So they're medicines like Strattera or Qelbree are 2 non-stimulants. Now, these are great medicines, and they don't involve appetite suppression. They don't involve insomnia, all the things that we're going to talk about in a minute. And they sound really like, well, that's perfect, Noble. I want to put my kid on that medicine. There's hardly no side effects. And I'm going to tell you this. Don't get mad at me. Medications that don't have side effects tend not to have effects. That's not true. That's not true everywhere for everything. Okay. Don't get mad at me, but I'm just saying it's true, right? But there are non-stimulant options. You can explore non-stimulants, medicines that will not impact your child's appetite and do address ADHD, but oftentimes not in the same manner as a traditional stimulant like Ritalin. And then lastly, you can consider appetite stimulants. These are situations where you're adding a medication to your child's medication regimen in order to boost their appetite. Now, if you've known me on YouTube at all, or if you follow me, I'm not a fan of adding medicines to things. I don't like medicines, not because they're bad, not because they're wrong, but because if we don't need to use them, let's not use them. Okay. And so when we add an appetite stimulant on top of something to try and get your kid to be more hungry, there are people who do it. I'm not one of them, but that is a strategy that people will utilize as it relates to weight. Now, before we move on to our next concept, I want to take a minute and help us all understand that not all ADHD medications are created equal. Right now, if your child is on an ADHD medicine, most likely they're on one of these 2. They're on a methylphenidate or they're on an amphetamine. Okay, a methylphenidate or an amphetamine. All right. And those medications have a bunch of names: Ritalin, Concerta, Quilvant, Adderall, Vyvanse, blah, blah, blah. All you need to think about in regards to our time together is, that you can switch to a less aggressive medicine if you understand which of these 2 categories is more aggressive. Amphetamines like Adderall and Vyvanse tend to be a little bit heavier. They tend to have a little bit more teeth in them, right? And again, I'm saying that both clinically, but also from experience, okay? And so if you're on a medicine that's an amphetamine base, like again, Adderall or Vyvanse, then you may be able to downshift to a less aggressive strategy, like a methylphenidate, like Ritalin or Concerta or Quillavant or some of the others. So think about that. If your child's on too much medicine and you feel like a less aggressive strategy could be helpful because of appetite suppression, maybe switch to a methylphenidate, maybe downshift. But if you're on a methylphenidate and you've been on several of them, again, there's several to choose from. Your choices probably are only going to go, if you're going to go to an amphetamine, you're going to a more aggressive strategy there, and you're probably going to have equal amounts of appetite suppression. If that's not been your experience, put it in the notes below, put it in the comments, and we'll talk about it. But that's been my general experience. Now let's talk about sleep next. All right. So if you remember, the reason kids who have ADHD who are on medicines don't sleep well is because the medicines manipulate the neurochemistry of your child's brain. And that's dopamine and norepinephrine, right? The fight or flight hormones are being activated, right? So you're not going to fall asleep in a knife fight. You're not going to be super hungry on a roller coaster, okay? And these medicines suppress, they suppress or they manipulate the neurochemistry of these neurotransmitters or of your child's brain. And that can result in some difficulties with sleep. Okay. So when you have sleep difficulties in a child on ADHD, this is how we handle it. Okay. This is the down, wait, stop, change paradigm for that specific problem. So almost never when I have a child present to the clinic and they have a problem with sleep onset, okay, almost never do I go down. And I'm going to tell you why. Because insomnia, right, is as a feature of ADHD medications, it has to do with presence or absence of the medication in the child's system. Okay. So going down doesn't, in my mind, it doesn't matter as much because the medication is still present in the child's system. It's about proximity to bedtime, not the amount of medicine they're taking, but how much medicine is left in their system as they approach bedtime. So going from 10 to 5 isn't probably going to be as dramatic of a change for you. It's about presence or absence. So I almost never go down. That's usually not an option when a child doesn't sleep well. Sometimes I wait, but that's usually only if it's a new medication strategy. The child's only been on it a couple of days. I say to the family, just wait a couple of days and let's see how things go, but only a few days. Sometimes I stop if it's really, really bad, but I usually have to ask a bunch of questions. I usually have to say, what time are they going to bed? They're like, well, they're going to bed at 9:15 instead of 7:30. And you know what I'm going to say. I love you. I think you're fantastic. You know what I'm going to say. Maybe 7:30 is not a realistic option for us. Maybe 8:39. Maybe that's more realistic, right? Maybe we don't have a sleep-related difficulty. Maybe we have a perception difficulty on sleep onset, right? So sometimes, depending on the dose, I will stop it, but it has to be, I'm talking to kids going to bed at midnight, 11 o'clock, 1 o'clock in the morning. And that obviously I'm not going to tolerate that for very long. We're just going to stop that dose depending on what it is. And usually it's a starter dose because it's a new problem. But sometimes what you have to do in the down, wait, stop, change paradigm as it relates to sleep is you have to do these things right here. I'm going to make it big. First and foremost, the thing that I want you to think about, the thing I want you to remember as parents is that this is an issue with timing, okay? Just because your child's on a medicine for ADHD and they struggle with sleep, it doesn't mean that they're always going to struggle with sleep. It means that the timing of when the medication is administered and how long it lasts is splashing onto the shores of bedtime, and that is something we need to change. So the first thing I'll do is say, when do you give the medicine? And you'll say, it's a medicine that, it's a long acting medicine. I give it in the morning but I give it at like 10:30 because, he goes to school later on Wednesdays or whatever. And then I say, well, listen, it's a 12-hour medicine. So you got to do the math, right? Give the medicine between 7 and 8, 6:30 and 8 a.m. And always, if it's a long acting once daily medicine. So sometimes I'll address the timing. If you're using short acting medicine, so sometimes you're on a short acting Ritalin or a medication over the lunch hour, or sometimes after school, like at 2 or 3 o'clock, because there's a bunch of issues or after school activities or things like that. Then I'll look at that and I'll say, well, what's the dose of your afternoon medication? And you'll say, 3, 4, 5 o'clock, depending on when I remember to give it. And I say, whoa, you're too close to bedtime. Okay, you got to drag it up to noon. You got to drag it up to 1 o'clock, and that's it. We don't go past that, depending on the kid. So sometimes we'll change the timing. Sometimes we'll change the formulation. Sometimes your child can't tolerate being on a long-acting medication, like a 12-hour medicine, right? They can't tolerate it. The sleep issues don't rectify. It becomes increasingly problematic. And so we have to go to short-acting medicines. We have to say, okay, we're going to go to short-acting medicine. We're going to do an 8 o'clock dose and a noon dose because they're 4 hours, generally 3 to 4 hours, and they're gone. Right? We have to stay as far away from bedtime as possible. So sometimes we have to change the formulation. Sometimes we go to a non-stimulant, right? So because those aren't going to cause you to have trouble with sleep onset. In fact, you can take a non-stimulant at bedtime. You can take it at bedtime, like, and it'll work the whole next day. So those, maybe you have to switch to that. But sometimes we have to use a sleep aid. All right. Now, I've already told you, I don't like adding medicines to treat side effects of medicines, but sometimes we'll do it because the benefits of an ADHD medicine are so dramatic. They're so dramatic. They're so fantastic. This kid's doing so much better in school, right? They go from impairment to, being functional and being able to show everybody how incredible and smart they are. So in that situation, then sometimes we will add a medication to help with sleep onset. Sometimes it's something as innocuous as melatonin. Sometimes it's something more aggressive, like clonidine or Tenex. It just depends. But it really has to do with a lot of factors. There's a lot of words on these slides. There's a lot of things to discuss because this gets pretty complicated. So my hope is you'll find your area of this talk that has to do with your child and the issues and difficulties that they're having, and you'll find some benefits from using the down, wait, stop, change paradigm. Headaches and GI upset. How do you apply this paradigm to that problem? Well, okay, let's talk about it. The first thing I do is if I've got somebody who says, look, headaches, GI upset, I don't really go down. Okay. I don't really go down. That's not my first move here because again, it has to do with presence or absence, right? If when this medication hits your child's gut, even if it's at a 5 milligram dose or a 40 milligram dose, your gut, if the child's gut is irritated, I don't think the dose is going to matter a whole lot. It's going to hit the gut and it doesn't like it and it gets irritable and you get gastritis and all the things, right? So I don't typically rely on going down on a dose to make this problem of GI upset or headaches go away, okay? But what I will do sometimes is I will wait, but only for a few days, because sometimes when you adjust the dose, sometimes when you're getting used to how the child's going to respond, maybe it's a new formulation. Sometimes giving it a few days is okay. You don't want to throw the baby out with the bathwater. You got to kind of let things sit, but not for very long. And of course, you can always stop. Of course, we've covered this, but here's what I really want you to pay attention to. Okay, if the medication is effective and you really feel like we're on the right track here, okay, there are some things that we can do while we wait for things to improve. We can push hydration. I talked about this yesterday. Listen, you want to know why kids get headaches? Now, not all the time, but you want to know why kids on ADHD medicines get headaches a lot? It's because they oftentimes don't drink. Not only do they not want to eat, which we covered earlier, but they don't want to drink. They don't want to drink. So their eyes get dry, their mouth gets dry. And when I don't drink anything and all I do is drink coffee, right, I get headaches. It's no bueno. It's no bueno. It's no good. So push hydration, take the medicine with food, right? Again, like when I was taking ADHD medications, okay? I mean, I was just like hammering a medicine and then drinking a cup of coffee. And I called it the developmental behavioral pediatrics breakfast. That's what I told. I was like, this is the breakfast of a developmental pediatrician. That's crass, but that's what it was to me. And it gave me terrible gastritis, right? Take it with food, right? Like put something in the child's stomach and soften it up. Take it with food. Sometimes, you have to not necessarily change the hydration status, change the food that you're providing or what you're giving it with. But sometimes you do need to change the medication at this point. Sometimes I do. Sometimes, it's a focal and it's hitting the gut and it's not a good fit and we'll transition to something else, or even something will go from a tablet to a capsule or a liquid or a chewable, something or a pro drug like Vyvanse to kind of, be metabolized elsewhere. Sometimes those kinds of strategies can soften the blow a little bit. And then sometimes, of course, if it's really getting at the gut, you can switch to a non-stimulant. But surprisingly, if there's any big side effect from a non-stimulant like Strattera or Qelbree, it's GI upset. It's like the number one. So I don't know that that's always the best option, but sometimes it's okay to try different things at this point. If things don't improve after a few days, you have to start making some changes, right? This is why sometimes it's hard to find people who will manage ADHD, honestly, because ADHD is one of those things where you don't get to set it and forget it. it needs to be fixed. It needs to be tweaked. It needs to, you have to tighten a screw, or you have to get out and oil something. I mean, it happens a lot. I see kids with ADHD every 2 or 3 or 4 months. I mean, I'll see them, multiples more often than their regular doctors will see them, right? So this is oftentimes why it's stuff like this. It's the down, wait, stop, change paradigm is why it's probably hard to find people in your community who are willing to manage these medicines, which is why we have to make videos so that you can give them ideas, I guess. All right, let's keep going. Jitteriness, tics, skin picking. If this is your kid, okay, this is how we are going to apply the paradigm to your kid. Okay, here's how we're going to do it. Let's make it big. Now, sometimes I'll go down on this dose. Sometimes I will. Sometimes I'll decrease the dose, because if skin picking and jitteriness and all these things have become an issue all of a sudden, okay, sometimes what I'll do is I'll go back to the prior dose if it was reasonably effective. Sometimes I say, look, we just pushed too hard. We pushed a little too hard. This is a little too hot. That's okay. Let's go back. Sometimes we'll wait, but really, as I've said, only for a few days. I'm not going to let you sit out there and on the struggle bus for 3 months or 4 months. That's not a good fit, right? Sometimes we'll stop. Of course, we talked about this, but let's make this big. So sometimes what we'll do is, we'll switch, right? So if I've got jitteriness, it's just not a good fit. Skin picking, licking, tics. A non-stimulant is going to be helpful. Okay, a non-stimulant is going to be helpful because you're not pushing on the same neurotransmitters in the same ways, right? If you switch to a non-stimulant, you can sometimes mitigate some of those issues that kids can have. But oftentimes, if a non-stimulant is not a good fit, or we need more support than that, a new medication. So maybe Ritalin wasn't a good fit, so we try Focalin, right? Just because one stimulant or one traditional ADHD medication resulted in tics doesn't mean they all will in the same ways, okay? So just hold on, hold tight, and let's keep trying stuff. And then lastly, let me say this. Okay, now you can kind of see what's happening here. When you use the down, wait, stop, change paradigm, we are trying to get the most possible out of the medication strategies because there's only so many of them, right? There's only so many things we can do. There's only so many levers that we can pull. And if we're treating a child who has legitimate impairment, we really, really, really want to try and figure out how to tweak and twist the medications as best we can to help your child be successful. Okay. And just as a reminder, put your questions in the chat if you've got them. All right. So, sometimes we'll use a non-stimulant. Sometimes we'll go to a new medication. And then sometimes if the medication's effective and we really like what we see and we feel like we're on the right track, what I will do is, hold on, we got a comment. Oh, wait, hold on. Here we go. Look at this guy. How effective is, this is an 8-hour methylphenidate capsule compared to Concerta. All right. So thank you, Dennis. It's always good to hear from you. In the States, I'm guessing that we don't have something on the market here that I can think of that's called Equisim, but we do have Metadate CD or Metadate ER, and that is an 8-hour methylphenidate capsule, and it's very good. I use it primarily for individuals who struggle during the school day, or maybe for you during the work day. And it compares to Concerta in this particular way. Probably 2 comparisons. The first of which is Concerta is a 12-hour medicine. Okay. So it's a 12-hour medicine. So you take it at 8, it should work until 8. Does it actually work until 8, Dennis? No, it doesn't. It works till about 4. Okay. But that's the first comparison, is that obviously if you've got a Metadate CD or an Equisim XL, if it's, the length, the duration of action is going to be different. So I'll use Metadate CD or ER, which is our equivalent, for individuals that just need that 6 to 8 hours of effect. And we only want to take it in the morning, and we don't really want to involve school, and we just want the least amount of effect. But there's a second difference probably between these two, and that's how they're pulsed. Okay. Now, again, this is getting in the weeds, but hey, you're watching these videos for a reason, because maybe you're struggling to find people in your community, or you don't have a good connection with your provider or whatever. So I'm trying to give you as much information as I can. Concerta is a 30-70. Okay. 30% immediate release, 70% sustained, maybe like 20-80. It's like right in there, but So you get an immediate burst at the beginning of the day, but it's not like a 50-50. So like focal and XR is an example of a 50-50, right? So it's a 50% burst at 8 a.m. and another 50% burst at like 1. It pulses, equally. Whereas Concerta is more like a slow burn, where it's like it slowly kind of heats up throughout the day, and it really has good coverage as the day wears on. Whereas Metadate CD or Equisem XL, it may be more like a 50-50. I actually don't know how that's bursted, but I'm betting it's not the same as Concerta because Equisem is a capsule, right? And again, Concerta peels off in layers as it moves through the gut. So I'm guessing Equisem is probably a 50-50. Is my bet. So take it for what it's worth, Dennis. That's how I see it, my man. Thank you for your question. I always forget this is live. I say it's live, but it actually is. Dennis says thank you. Dennis, you're fantastic. Okay. So again, back to this idea of adding or augmenting a medicine. If your child is struggling with tics and jitteriness, and you're like, oh, but the medication's so effective, right? They're skin picking their fingers, and it's hard to watch, and you're just like, but should we stay on? Should we not? Sometimes I will add or augment onto an ADHD medicine. I'll add 10x or clonidine, okay? Because I want the medication to be effective, and I want to continue to help your child be successful. And so I'll add those medicines maybe twice a day. And those are blood pressure medicines. And we're not going to get into the weeds on that, but they can really be helpful with motor tics, irritability, jitteriness, and they can help mitigate some of those side effects. I've said it 100 times, I don't like adding medicines to treat side effects, but sometimes if the medicines are effective and things are dramatically better, sometimes the juice is worth the squeeze and we try. Okay. Now let's talk about emotional and social. If you're watching this and you're like, well, my problem is not weight and it's not jitteriness and it's not appetite, it's not that stuff. My problem, Noble, is that my kid gets irritable. I mean, the connection between them and I is getting broken. They come home from school and it's just no one's happy to see each other. And that's not the way I want to live my life. And I say, okay, those are social and emotional problems. Irritability, anxiety, mood swings. Let's talk about it, right? Let's talk about this guy. This guy is a good guy, but sometimes he gets really frustrated when you put him on an ADHD medicine, all right? So what do? How does the down weight, stop, change paradigm apply to irritability and outburst behaviors? Well, sometimes if this irritability is dramatically different because I've manipulated the dose, sometimes I'll go back. Sometimes I'll say, okay, oops, pushed a little too hard there. Maybe the effect that we had before we increased the dose is as good of an effect as we're going to get without spinning this kid out. Let's go back to the prior dose and leave it sit. So sometimes I'll do that. All right. Sometimes I'll wait, but honestly, in this situation, if I've got a kid that's blowing, that's irritable, where the connection is being broken between the child and the parent, I'm telling you, my friends, it's not worth it. I don't care. I don't care about progress towards their IEP goals. I don't care about, their talented and gifted programming or how amazing they're doing, how many gold stars. I don't care. I do not care. If their connection is being broken between in the family, then we stop. We're not going to wait around. We're not just going to hope for the best. We're going to do stuff. So that's when I'll advocate for either stopping the medicine, depending on the dose. But if we have to continue, right, because again, irritability is something that we're willing to deal with. Maybe there's things we can do to make it better. Can we mitigate this to some extent? So we can go to a non-stimulant, right? Of course, you've heard me say that a bunch of times. We can use a less aggressive stimulant medication. Remember, I showed you that slide, right? Where it's like, if you're on an amphetamine product, like an Adderall or a Vyvanse, maybe you can downshift to a methylphenidate product, like a Ritalin or, Concerta, something else to soften it a little bit. And you say, well, we did that, Noble, but it didn't really work. And then I would say to you, yeah, okay, but that might be the best that we can do here. Okay. Like that might be the best that we can do. And I'm sorry that we're not going to be able to dial it in completely, but sometimes you have to live with the results of a less aggressive medication. And that's just the way it is. And then sometimes we have to add a medication. And a lot of these themes are recycled, right? Because there's really only so many levers you can pull. But the truth be told, sometimes adding a medication after they get home from school, listen to me, after they get off the bus, right? And the medication is worn off and they're irritable and they're aggressive and you're just like, sometimes if we add a dose of a medicine right there, right? Not a stimulant, not something that's going to mess with sleep, not something that's going to keep them awake. Not that, But something like a low dose blood pressure medicine, which again, don't get mad at me. Don't throw stuff at your computer screen. You're like, this guy's nothing but a blah, blah, blah. You're going to say that anyways, but it's okay. We'll use a low dose of that because think about it like a plane is crashing. Okay. A plane is crashing on the runway and we know it. The landing gear won't come down. So when you use 10x or clonidine, these kind of blood pressure medicines at low doses, and okay, they're not great blood pressure medicines. All right. No offense to cardiologists who are out there and are mad at me, but in general, they don't really move the needle on blood pressure that I've seen in my clinic. But what they do is they relax kids. They calm people down. So if a plane is crashing in the sky, putting 10x or clonidine out there is kind of like throwing a bunch of pillows on the runway. It's like, let's just throw a bunch of pillows out there and maybe it won't hurt as bad when the plane smashes, right? That's what it's like. Okay. It's not aggressive. It's not over the top, but sometimes it's just enough to smooth out the irritability and maintain a little bit of connection while still benefiting from an ADHD medication during the day. Lastly, here's our last topic we're going to talk about. We talked about this yesterday. You got a zombie, right? You got this kid who's just withdrawn, right? And again, they're not a zombie in the traditional sense. What I mean by zombies is that, they're withdrawn. They're not funny. They're not interested. They're just like staring off and pondering the cosmos, thinking about crystals and, spiders. I mean, that's not acceptable. And what are we going to do about that? How are we going to apply this paradigm to a child who's just too withdrawn? What are we going to do? Sometimes, like before, I'll go back to the previous dose because maybe we pushed too hard. Maybe I pushed too hard. Let's go back to the previous dose. I never wait. Listen to me. I never wait. I hate this. I'll come into clinic and sometimes I'll see a kid on a new evaluation. Somebody's been referred to me from somewhere else and they're on a medication. They've been managed locally and I'll come in and I'll be like, is this how this kid normally is? Because this is a 7-year-old kid. And I'm not the world's funniest guy, but I'm animated enough that you're either going to love me or hate me. But like, you got to give me something. You know what I mean? And if I can't get either one, if I can't polarize this child in either way, then that kid's on too much medicine. Too much medicine. Oh my goodness. And if you followed me around for a week, you'd know exactly what I'm talking about. Like these kids, I never wait. I get going right away. Yep. Sometimes I'll stop these medicines and I don't even care sometimes about the dose. Like obviously we're going to be careful if they're on high level doses, but if they're that withdrawn, they're just that inside of themselves. No way. We're getting off that right away. And then people are going to say, but Noble, he's going to be hyperactive and impulsive and inattentive. And I'm like, guys, I'm with you. I feel it, but we got to clear the air. Let's get the smoke out of the room. There's just too much smoke and mist in here. I can't even see what we're doing. Clear the room and then let's see what we got. Give me a couple weeks, just clean off all medicine and let's see what we're working with, man. Sometimes I'll go to a non-stimulant. Sometimes I'll go to something that's less aggressive, right? These are all things that we can do when we get all the way around to the paradigm of change. Maybe we do change. Maybe we try something different. But a lot of times I'll try a less aggressive medication strategy, or as I've said earlier, a less aggressive dose. That, my friends, is the down, wait, stop, change paradigm. And I know there's a lot of words. I just said a lot of words. I said a lot of blah, blah, blahs. But this is recorded. It's on YouTube. You can go back. You can find the timestamp that matters most to you. And you can watch that portion of it. And hopefully that will give you what you need to advocate in the right direction for your child. No one's asking you to be a provider. I'm just asking you to make the hard decision. Is the juice worth the squeeze? Because if I have my ideal situation would be nobody's on any of these medicines, right? Not because they're bad or they're wrong and not because you're doing a bad job. You're awesome and you're fantastic. And I prescribe these medicines, but it's because, I just want to make sure that when we're helping your child, we're doing the least amount possible to keep them on track, the least amount. And what we talked about during our time tonight is what happens when we're doing more than the least amount and we got some problems. Okay. And then we have to make some adjustments. All right. So listen, if this is helpful to you, you know what I'm going to say. I want to talk to you a little bit about saffron, but if this is helpful, like and subscribe because then I can get this to a lot of people because there's a bajillion people out there who are on wait lists for people like me and they just need to be told this. Like they just need to be told the things that I just told you. That's it. So like and subscribe and I promise you it'll get to them faster. You know what I want to talk about later this week with you? I want to talk about saffron and ADHD. Yep. Saffron and ADHD. There's some articles coming out on this. It's legitimate research. It seems fantastic. There's dosing that we're going to talk about. I want to talk to you about why it works and why you should maybe think about it as a potential option and how it works and the science behind it. Like and subscribe. Thank you for watching. You're awesome parents. Be nice to yourself. I will see you guys maybe tomorrow.